Today we are going to have a quiz on fetal arrhythmias. So going to be sort of a brushing up of whatever we have learned last month. So we'll start with the first slide. This is a figure which was taken during a fetal echocardiogram of a baby who had a structurally normal heart and had a ventricular rate of 130 beats per minute. What does this figure show? I can repeat, this is a fetal echocardiogram, a figure taken during the study of a baby with a normal heart structurally and had a heart rate of 130 beats per minute. Yes, so this is M mode of the atria and the ventricle. As you can see here, this is the atrial activity and this is the ventricular activity, which shows atrioventricular coordination. So as you can see, M mode is one way to find out what is happening to the rhythm of the baby's heart, and we need to understand that there are certain limitations of M mode. Can you name some limitations of M mode? Poor windows, yeah. One of the major causes of poor windows is probably when the baby develops hydrops because of some reason, or if there is polyhydramnios. So in that situation, the movement of the atria and the ventricles may not be great and it might be difficult to appreciate. The second thing is, compared to a Doppler study, M mode, the atrioventricular interval or the VA interval is a little vague. It's not as accurate as what we can see on Doppler study. You can also do an M mode of the left ventricle, where you can have mitral valve movement seen, and as you can all see here, this is the D point, E, F, A, B and C. Now if you can get this cut of M mode of the left ventricle, how do we mark the atrial and the ventricular activities on the M mode? And this marking would be more accurate compared to the M mode which we saw already in the previous figure of the atria and the ventricles. So this is the M mode of the left ventricle with the movement of the mitral leaflet C. How do we mark the atrial and the ventricular activities in this figure? This is the E point and this is the A point. This is very similar to the Doppler study of the mitral inflow. So these waves are similar. Can we make out the atrial and the ventricular activity? Yes. A is the atrial contraction and C is the ventricular contraction. So this would be a little more precise compared to the previous M mode to figure out what is happening to atrial and ventricular activity. The other way would be to see aorta and left atrium, and the onset of atrial activity can be onset of the LA movement, and the ventricular activity can be demarcated by the opening of the cerebellar valves. So this is how we can differentiate the atrial and the ventricular activity. Now the second way, which is the second cornerstone for picking up the atrial and the ventricular activity, is the Doppler study. Now if you can see in this figure, this is a Doppler taken very close to the inflow of one side of the heart, probably the left atrium and the left ventricle. Can you identify the waves which we have demarcated as A and B, and the interval which is shown with this line? So what are these waves? This is one wave and this is the other wave. we are seeing? This is the Doppler taken at inflow-outflow junction. Can anybody identify the waves and the interval which is shown with a line in this figure? What is A indicating and what is B indicating? TR. I don't know what to take it from TR wave. TR is tricuspid regurgitation. This is not tricuspid regurgitation. This is an inflow-outflow Doppler. So if you can take a mitral inflow and outflow Doppler, this is the outflow, this is the ventricular activity, and this is the inflow. This is the E and this is the A wave. As you can see, the E wave velocity is lesser than the A wave velocity. So this is the atrial activity and this is the ventricular activity. So as you know, this is the E and the A wave. This interval which is indicated in this diagram is starting from the beginning of A wave to the beginning of ventricular activity. So this is what is the PR interval. Just a revision of what we had learned in the last class. As you can see in this figure, this is the outflow and this is the inflow. So this is the E and the A wave, and the beginning of the A wave to the beginning of the ventricular contraction indicates the PR interval if you can correlate in this ECG. So in a similar way, this is E and A, and when you start from the beginning of the A to beginning of ventricular contraction, this is the PR interval. PR interval is important for us. We have values for all gestational age groups, and it depends upon the technique to measure the PR interval. The value varies. On an average, it ranges between 100. On an average, it ranges between 100 to 125 milliseconds. Can you hear me now? Is it okay? Yes. So now, with this understanding, we will go with the next question. In general, we know that we want atrioventricular coordination and the atrial and the ventricular rates to be the same. Can you name some conditions when the atrial and the ventricular rates are not the same? Can we have some conditions where the atrial and the ventricular rates are not the same? So we are getting answers. Ventricular tachycardia. Yes, when the ventricular rate is going to be more than the atrial rate. Atrial tachycardia, ectopic atrial tachycardia can have a block. Atrial fibrillation, yes. Atrial fibrillation is extremely rare in a fetus, but it could be flutter. So we have a couple of answers here. Atrial flutter. Premature atrial contraction, which doesn't get conducted, will have ventricular rate lesser than the atrial rate. And we can have ventricular tachycardia and junctional ectopic tachycardia. One most important is complete heart block, where the atrial rate is more than the ventricular rate. Now, if we see the other way, especially when we have either atrioventricular block or ventricular atrial block, as we saw in the previous conditions, is there any condition it clearly rules out? That means that we don't have the atrial and the ventricular rate similar. Does it rule out any specific condition? We can be sure that it's definitely not that type of arrhythmia. Yes, atrioventricular type of reentrant tachycardia can be definitely ruled out. So with this understanding, now we will go with the first figure. You can all closely observe the running image I will play it once again, and you can keenly observe grossly the heart is structurally normal, but if you would pay attention to it, you would realize that there is something wrong with the way it's beating. Yes, and then the Doppler taken at that point in time is as what is seen in the second figure. Can you suspect the diagnosis? I can play it once again, but the Doppler is as shown in the second figure. As you can see in the second figure, this is the atrial activity and this is the ventricular activity. Again, this is a Doppler study done at mitral inflow and aortic outflow. Yes, at that point in time, can you see something wrong with the rhythm of the heart? Atrial ectopic, yes, that is correct. And as we can see here, this is the E and this is the A wave. So what happens when we have an atrial ectopic is, if it's not conducted, it will continue, the mitral inflow continues till the next cycle. So this is an atrial ectopic. Now this is a scenario where you would have irregular rhythm. So as you can see in both the figures, can we suspect what is happening in the first figure? With AV dissociation, we wouldn't call it as AV dissociation, but it's practically an atrial ectopic in the previous figure, which wasn't conducted. So as you can see in this figure and this figure, both these conditions would have irregular rhythm. Is it different than each other? There's something wrong here in this figure. So the first picture, you can see it's actually not a ventricular contraction. Why is it not a premature ventricular contraction? We will see it in the second subsequent slide. Now if you can see here, this is very similar to what we had seen in the previous figure. If you can see here, this is the atrial activity and suddenly the E wave is seen and then the inflow continues till the A wave, till the next beat where it is conducted as ventricular contraction. So if you can see in this figure also, what is happening is this is still the E and the A wave, E and the A wave, and so this is the E wave and it's continuously prolonged. So this is again a premature atrial contraction which is not conducted versus here you can see EA, and this is a premature atrial contraction which is coming in a time where it gets conducted. And still there will be a little irregular rhythm, but the ventricular rate is going to be the same. So this is a conducted premature atrial contraction. Yes. So when you have a premature atrial contraction, what do we do? Do we treat these atrial contractions? Do we tell the mother nothing to be done? What do we do? Whenever we have a premature atrial contraction, what do we do? How frequent is a very important question, and if it's happening less than 1 in 10 beats, we would consider it as not frequent ectopics. But say if it's happening more than 1 in 10 beats, do we do something? We would definitely want to see the heart structurally to rule out if there are any tumors, if the ventricular function is okay, is there any evidence of myocarditis. But understanding that structurally the heart is completely normal, whenever we have ectopics, it is something which we need to remember that most of the times they are benign and they may not persist. But if it's more than 1 in 10 minutes, it is important for monitoring closely because occasionally this baby can go into SVT. Important is to tell the mother to make sure the fetal movements are well perceived and to avoid excessive amount of K-fill. So this is how premature atrial contractions are followed up. Now we will go to the next slide. Okay, so here we can see in this figure, this is a Doppler study done of right ventricular inflow and outflow. So what we are seeing on the top, it's named well E and A waves and then the ventricular contraction. Is there anything wrong in this figure? 500 milliseconds RR interval is normal for a fetus where the ventricular rate will range around 130 to 140. Bradycardia, 500 milliseconds will give you a heart rate of around 130 to 140, and as you can see here, there is atrioventricular coordination, but suddenly there is something wrong here in the last beat. What has happened is, this is the mitral E wave and the A wave is completely abolished. Whenever the A wave gets aborted, it happens when there is a premature ventricular contraction. So this is how these babies also would present with irregular rhythm, but this is premature ventricular contraction. And how do we diagnose them? The A wave is missing in the inflow Doppler. So this is ventricular ectopic, and again we would screen out the structural heart problem. Otherwise, see how frequent they are happening. Yes, VPC. See how frequent they are happening and manage them closely if needed with normal function. Now we would come down to one running image, and if you could just see the image, you could feel that there is something wrong, not in the structure of the heart. So what is the diagnosis? Just on 2D, is it possible for us to suspect anything in this baby? This is the 4-chamber view of the heart, and structurally the heart is normal. This is descending aorta, this is the right heart, and this is the left heart. Is there anything wrong on the 4-chamber view? As so far we have seen, Mood and Doppler studies are cornerstones for diagnosing arrhythmias. However, you can also suspect arrhythmias on 2D. Just seeing the 4-chamber view, just getting an understanding of the heart rate, the squeeze of the heart, etc. Anybody? Just in general, does it feel that the heart is beating very fast? This is just a heart which is beating very fast. In general, it's more than 200 beats per minute. This is some form of tachyarrhythmia. No, it's not heart block. It's not bradycardia. If you can closely, I will play it once again. You can see that the heartbeat is very, very fast. It gives an impression that the squeeze is not normal. I'm getting answers of complete heart block from everywhere, but this, if you can see this, the contractions are very, very fast. You can see the rate at which the mitral and the tricuspid valves are moving. This is not a normal beating heart. Yes, this is a type of tachyarrhythmia. We don't know what type, but it's some form of tachyarrhythmia. Now, when you suspect tachyarrhythmia, what structural heart diseases would you like to rule out? Can you have an associated structural heart disease with tachyarrhythmia? Epstein's anomaly of the tricuspid valve, that's correct. Corrected transposition of great vessels, and it can also happen with myocarditis and cardiac tumors. Now, when you say corrected transposition of great vessels, usually isolated CTGs will have atrioventricular blocks. But if you have CTG within its field, you can again have accessory pathways and you can have SVT because of that. But isolated tachyarrhythmia, you need to rule out cardiac tumors and myocarditis. Now, once we know that the heart is beating so fast, why are we worried about it? Because we know that it can produce hydrops or even before that, hemodynamic compromise. So if there is a full-fledged hydrops, everybody can make out because there is a lot of effusion, ascites everywhere. But how do we check for hemodynamic compromise? So once we see a structurally normal heart with tachyarrhythmia, yes. So we would see IVC and ductus venosus Doppler. We would see if they are dilated, if there is any flow reversal or any Doppler waveform pattern is changed. Is there anything else it would affect? As you can see in this heart, there is some amount of cardiomegaly. In general, if you see, this is the chest diameter, AV valve regurgitation. Yes, very important is AV valve regurgitation. Heart size, CFO gradient may or may not be affected based on the compliance of the ventricles. Okay. So that's correct. We can have atrial enlargement, cardiomegaly, AV valve regurgitation. A little later, the ventricles get dysfunctional and flow reversal in distended IVC and hepatic veins or ductus venosus. Now we can see this figure. This is a mode of the ventricle and the atria, and you can see that the rates are different. This lady came in the 3rd trimester. She's a 23-year-old primate. So as we saw some time ago, 500 milliseconds is the normal RR interval. Can we, yes, correct. So this is a tachyarrhythmia because the RR interval is 280 milliseconds. So that's correct. And most commonly with this, when the rates, ventricular rates are between 200 to 50, atrial rates are 400 to 500. The most commonest diagnosis would be atrial flutter. That is correct. With 2:1 AV conduction. That's correct. So this is flutter with 2:1 AV block. And what is the drug of choice? This is a little different compared to the SVT flutter. What is the drug of choice? In general, digoxin is considered to be safe, but sotalol is the drug of choice according to the protocol. Digoxin can also be considered, but for flutter, sotalol is considered to be the first drug of choice. Amiodarone is not considered as a first line medication in view of its side effects. So we can just go back to that chart which we had seen last time. A flutter gets diagnosed whether there is hydrops or not. Sotalol is the first drug of choice. In general, digoxin is considered to be safe and with a success rate of 50%, but for flutter, sotalol is considered to be the first line of medication. And then after 3 days, if there is no change in the ventricular rate, then the dose is increased and then digoxin is added as the combination treatment. Now coming to the next slide. This is a Doppler done at the inflow-outflow level of the left ventricle. You can see that there is something similar to what we had seen a couple of slides before. So what is happening? She was referred for a fetal heart rate of more than 220 beats per minute. Yes, so this is correct. This is premature atrial beat which has caused supraventricular tachycardia. Now in this it has happened in front of us, but in general when somebody gets referred with heart rate of 220 beats per minute, how do we know that it's going to be persistent? Does it matter? SVT can be temporary, can be persistent. So how do we define persistent SVT? This is important for us because there is a little debate about what to do when the SVT is transient. It doesn't remain for a longer time. So for that, persistent SVT has a standard guideline for management. How do we know SVT is persistent? Persistent SVT is a tachycardia which is lasting for more than 12 hours, especially when the heart beats are more than 220 beats per minute. So when it's persistent SVT, it is an indication for maternal drug therapy because these SVTs very commonly will end up in eye drops. So if it is more than 230 beats per minute for more than 12 hours, it is persistent SVT. And again, whenever we pick up SVT, we run through the protocol of whatever high risk factors are present. And if the mother is around 35 weeks of pregnancy, then it's better to deliver the baby. Otherwise, consider transplacental treatment. And again, running through the chart for SVT, which is non-hydropic, oral digoxin is the drug of choice. Oral digoxin, 1 tablet twice a day, and remember not to forget the mother. The mother needs to be screened so that there are no side effects, and whenever there is a change in the therapy in terms of addition of a new drug or increase in the dose, then the mother needs to be re-evaluated. So digoxin, 1 tablet BD for 3 days needs to be started, and we need to wait for at least 3 days. In absence of eye drops, the response is usually obtained in 48 to 72 hours. In contrast, when there is eye drops, the response can take as much as 7 days, where IV digoxin is considered to be the first line of management, and if it doesn't, then Corberon can be considered. Okay, so coming to the next slide, we can see one running image. This is a 34-weeker referred for suspected tachycardia, and as you can see, on M mode and Doppler, the rates were around 195 beats per minute. Okay, so you can see here in this figure, this is the color Doppler of the 4-chamber view. This is a structurally normal heart. Heart rate of 195 beats per minute. What is the possible diagnosis? So this actually gives you a question: what is defined as an abnormal tachyarrhythmia, in the sense that till what limit can be considered a rate to be normal, within normal limits. This fetal heart rate was 195. It is fast, but it's not as fast as what we had seen some time ago. Okay, so I'm getting different answers. Somebody is saying it's an ectopic atrial tachycardia. Somebody is saying it's normal. I would agree with both of you because it can be, you can see in this range, it can be sinus tachy, or it can be ectopic atrial tachycardia or SVT. I would consider these two as the first two possible diagnoses. But if you could pay attention to the second figure, you can see that there is some amount of AV valve regurgitation. Both the valves are leaking and the heart size is big. Normally, the cardiothoracic ratio will be around 0.5, but in this it's around 0.65. So there is some cardiomegaly with AV valve regurgitation, and hence we know that the heart is not liking the rate which is a little faster, and this actually turned out to be an ectopic atrial tachycardia. In general, when the rates are in this range and if the baby is tolerating it well, it's not an indication for transplacental treatment. Okay, now this figure is, as you can see, this is the SVC. This is the 3-vessel view. This is the SVC, this is the aorta, and this is the pulmonary artery. So this is the Doppler which is taken at the aorta SVC junction. So far, whatever Dopplers we have taken were at LV inflow outflow, and this is aorta and SVC. So if you could see in this figure, this is aorta and SVC, and you would see waves like this. SVC has S, D, and A waves, and the aorta has one single ventricular contraction. So if you can see this Doppler, this is very similar. This is the ventricular contraction, and this is the E, S, and the D wave, and this is the A wave. The heart rates are around 207 beats per minute. So there is some amount of tachyarrhythmia going on. Can we come to a provisional diagnosis? Just seeing the Doppler. The heartbeats are on the far side, and as you can see in this figure, we have shown some intervals also. So it is a tachyarrhythmia. Correct. So it is a tachyarrhythmia where you have a shorter CR and a longer RP interval, where the first commonest possibility would be ectopic atrial tachycardia. That is correct. And ectopic atrial tachycardia needs to be managed like SVT in case it fits into the criteria of it being persistent and any evidence of hemodynamic compromise. So long RP tachycardia most commonly in fetal life are ectopic atrial. Short RP most commonly are atrioventricular reentrant tachycardia. Now coming down to the slides, maybe we have 2 or 3 slides now, and we can see this is the 4-chamber view. Structurally descending aorta, left heart, right heart. This is tricuspid valve, so it's AV concordance. Structurally, it's a normal heart. This is also just an impression based on how the heart is detailed. Can we suspect anything based on this? You can see attention to the ventricular contractions. Any answers? The ventricles are not contracting normally. You can see that the ventricular rate is significantly on the lesser side. And if you see the fluttering of the atrial wall, though it's difficult, we know that it's much faster. This is significant bradycardia. Most likely complete heart block, but would be difficult to say only on a 4-chamber view. Along with that, the heart is big, the squeeze of the heart is not normal, and the valves have started leaking. So it is a case where we have bradycardia, probably complete heart block, with some amount of hemodynamic compromise. So in cases of complete heart block, are there structural heart diseases you would look for? Would you look for any structural heart disease? Corrected transposition, that is correct. Corrected transposition, that's correct. Anything else would you like to look for? Atrioventricular septal defect, SLE in mother, correct. Getting lots of answers. Corrected transposition, SLE, AVSD, and isomerism. You can have heterotaxy syndrome with complete heart block. And in this, it's important for us to know that when it is associated with structural heart disease, in contrast to isolated complete heart block, the prognosis is not good. In general, in fetal life, when we pick up complete heart block with either of the structural heart diseases, the mortality is around 40%. Especially with atrioventricular septal defect, complete heart block combination means more than 90% chances the baby will not reach term. Isolated complete heart block most of the time behave well and end up needing something at birth. Now what do we do when we see a heart like this, rates of around 55 beats per minute? Can we give any drugs? Theoretically, do we have any drugs we should consider in complete heart block? So there is a lot of controversy about starting something where a complete heart block is already established. But if this suppose turns out to be a 2:1 AD block or a recent onset of a complete heart block with documentation, yes, we could consider starting steroids or beta stimulation. Yes, dexamethasone or beta stimulation, and to some extent it increases the rate and reduces the morbidity in babies at birth. However, once the complete heart block is already established, most of the people believe that there is no role of dexamethasone at that stage. Whenever we start dexamethasone also is not completely safe during pregnancy, and it started with a dose of 4 milligrams, which in a couple of weeks is shifted to 2 milligrams, especially in third trimester. And when we start dexamethasone, it's important to monitor a couple of things, including maternal blood pressure and Dopplers in the baby for placental sufficiency. Now, this is again a 30-year-old was referred for bradycardia. So the heart rates are on the lesser side, and this is the inflow, this is the outflow, this is the ventricular activity, and this is the atrial activity. Because we don't have the heart rates here, it gets difficult, but this is the point when the heart rate has dropped. Anybody? Yes, this is AV dissociation, that's correct. So here you have AV association, and this is one atrial beat which has not been conducted. So it was a transient 2:1 AV block. This is the point where you should give it a thought if it's there and should be considered giving steroids. So this is AV block, 2:1 AV block which has been transiently recorded. Now I think this is the last slide, and this is a mode of the atria and the ventricles. Anybody? This is a mode of the atria and the ventricles, and you can see that this is the atrial activity. 1, 2, 3, 4, 5. These are the atrial activity, and these are the ventricular activities. As we discussed some time ago, it is little difficult to figure out sometimes complete heart block. So I would agree that whenever the atrial rate is more than the ventricular rate and there is related bradycardia, you would consider it to be a complete heart block. A little carefully, if you will see that this atrial rate is not regular. If you could see this atrial activity, so this PP interval is not regular. If you could see, this PP interval is little bigger than this PP. So is there any other possibility in this situation? Whenever you have bradycardia with atrial rate more than ventricular rate, one common possibility is complete heart block. Yes, one common possibility is complete heart block, where you would want the, okay, I'm getting Venki back, but this is a very short script for me to say Venki back. Any other possibility? 2:1 AV block. Okay, so here you could see that PVCs. Yes, that is correct. So there is alternate. You have one normal atrial activity with a atrial ectopic which is not conducted, and then again you have a normal atrial activity and then an atrial ectopic which is not conducted. So you have a atrial bigeminy with non-conducted PVCs in between. Now I think it's just sort of a revision. I will show you the next slide in general how to differentiate bradycardia. But what are the other conditions where we have atrial rate more than ventricular rate? We have already gone through this. Can we just do it once again? Other conditions where atrial rate is more than the ventricular rate. So one is complete heart block. Second is when you have atrial ectopic with non-conducted beat, atrial tachycardia with block, correct, and flutter with block. So these are the conditions where you will have atrial rate more than the ventricular rate. And just to brush up, last time we have seen this slide. So whenever you have bradycardia, it's important to see atrioventricular coordination. You can have atrioventricular coordination where it could be a sinus bradycardia and where mother's thyroid rho antibodies need to be done. And QTC should be, in general, it can be a prolonged QTC which can manifest as Brady-Tachy syndrome. The other possibility is where the atrial rate is more than the ventricular rate, where it could be a complete heart block or 2:1 AV block, or it could be a PAC which is not getting conducted. In which situation we would again follow the same protocol of structurally normal heart, low antibodies to be ruled out, and if the fetal heart rate is less than 55, give it a thought whether medications can be given to the mother. I think we are, this is the end of the talk, and I would like to thank all of you. If you have any questions or you would like to go back to any of the slides, please. Okay, then if there are no questions, thank you very much and have a good day.